Hello. Hello, everybody. I am Prudence B. Aquino, the president of the PSGE. Welcome to our fifth webinar and the second of the PSGE Karl Storch series. We at the PSGE are wearing our national costume, inspired outfits to commemorate the recently celebrated National Heroes Day of our country last August 31. This afternoon, we not only honor our heroes of the past, but the new heroes, the medical frontliners helping our country win the fight over the current global health crisis. I would like to join everybody for a moment of silence to pray for our selfless Filipino frontliners. So to continue on a happier note, we are now in the Burr months, September, the start of the Christmas season in our country. And I'm happy to welcome our international faculty this afternoon during this time. I first met the professor over a hot pot dinner in the APH Congress in Chongqing, China last year. Thank you, Professor, for participating this afternoon. My heartfelt thank you to Karl Storch for the support you have extended. And to my dear friend and Vice President, Dr. Tonette Habana, thank you very much for all that you and your team have been doing to make our webinars very exciting. And before I proceed, can I have the slide for the announcement? Okay, so the PSG will hold a special meeting and election on October 21. So we have announced earlier that we will not be holding an annual convention, and in its place, we shall be holding a special meeting with a virtual special meeting on October 21 between 3 to 4 p.m. to take the place of the annual convention. And also during this time, we shall be having an online election which will take place same day and will start from 8 a.m. to 2 p.m. Links with this will be sent to the registered qualified voters. Thank you. Next slide, please. And to continue, let me now introduce the chair of the moderating team, Dr. Ana Belen Alenzuela. She's a professor of the Far Eastern University Nicanor Reyes Medical Foundation Institute of Medicine, a chairperson of the medical specialists for Department of OBGYN among R. Rodriguez Memorial Medical Center, chief section of the REI and NICS Department of OBGYN FEU Medical Center, Jose Reyes, and the Paulino J. Garcia Memorial Medical Center. She's an officer and board of trustees of the PSGE and the PSCM, a fellow of the POGS, fellow of the PSRM, and the PSGE. Friends, let's welcome Dr. Ana Belen Alenzuela. Thank you.
Good afternoon, everyone. Good afternoon. Thank you very much, my dear President, for that introduction. So we welcome you again in this webinar series. You know, the Philippine Society for Gynecologic Endoscopy is really working very hard through the leadership of our President and our Vice President, trying to bring you the best of the best among all of our webinar series. So I hope you will be learning again this afternoon. So it's afternoon here, Professor. Good morning from that part of the world. Okay, so before we continue, I would like to read some house rules again. Can we have the next slide, please? For this afternoon, participants other than the speakers are muted. Kindly send your questions via the Q&A or in the chat box. We'll try to gather all the questions, and my co-chair with me will try to deliver the questions to our simpatico speaker. Okay, you're going to enjoy him. Very, very wonderful speaker. Questions will be addressed during the open forum, and this webinar will be recorded for future viewing. Thank you very much, everyone, for your cooperation. So at this point, I would like to introduce my co-chair, a very, very good friend of mine. She's Abat Girl. She is currently the president of the Philippine Society for Reproductive Medicine. She's the secretary for the Philippine Society for Gynecologic Endoscopy. She's currently the chairman of the Department of OBGYN in Victor Potenciano Medical Center, the section head on section of reproductive endocrinology and infertility in the Department of OBGYN in the Medical City. Ladies and gentlemen, I give you my partner for this afternoon, Dr. Marinela Agnes Abba.
Thank you, Dr. Annabel Valenzuela, for that introduction. Now, I am very honored to introduce to you two of our distinguished speakers for this afternoon. Can I have the next slide, please? Our first speaker is Professor Elder Bruno Ferreira. He's Professor Auxiliar Convidado in the Instituto de Ciencias Biomédicas Abel Salazar, Universidade de Porto. Head of Minimally Invasive Gynecologic Surgery, Unit of Centro Materno Infantus de Norte, Centro Hospitalar Universitario de Porto, and also the Medical Director of the Centro Hospitalar Universitario de Porto, Largo de Professor Abel Salazar, and also the head instructor of the European Academy of Gynecological Surgery in Leuven. Our reactor for this afternoon, next slide please. Next slide please. Our reactor this afternoon is Dr. Herman C. Tan Cardoso II. He is the immediate past president of the Philippine Society for Gynecologic Endoscopy, the chairman, Department of Obstetrics and Gynecology, East Avenue Medical Center, and Fatima University Medical Center in Antipolo. He is the past chair, Department of Obstetrics and Gynecology at the Amang Rodriguez Medical Center and World City Medical Center. He took his subspecialty training in gynecologic oncology in UP-PGH and in UP-PGH. He had their scholarship training in gynecologic oncology at the Royal Women's Hospital, Melbourne, Australia. He had a scholarship grant of the International Gynecologic Cancer Society. He took his advanced laparoscopy at the Asia Pacific Association for the Gynecologic Endoscopy in Shanghai, China. So this afternoon, help me welcome our first speaker, Professor Elder Bruno Ferreira. Professor?
Hello, good afternoon, everyone. It's a huge pleasure and honor to join this webinar. I want to thank the kind invitation to the Philippine Society of Gynecological Endoscopy. I am from Porto, from Portugal, and I will share with you some experience, some knowledge, some tips and tricks about a topic of paramount importance, that is the total laparoscopic hysterectomy. We know that after C-section, the hysterectomy is the most commonly surgical procedure performed in gynecology. So it's very important, and I will focus in the details and sharing several videos. And at the end, please do not hesitate to make questions. So during these pandemic times, we have changed the focus of our efforts on how we adapt to live or our life with this COVID in the new normal of surgical practice, education, and research. The surgical training has been deeply affected in different ways. New avenues of academic training will need to be explored. Platforms of remote academic training are being developed and potentiated, including teleconference, webinars, and other online educational material like we are doing now. As you can see in this interesting paper published in the Annals of Surgery, we have to be prepared for these times and use these new tools to communicate and share the knowledge. Portugal, you see, is the most Western country in Europe. There is a long way between us. Fernando Magalhães, in the 16th century, he took months to all this way around African coast and arrive in Philippines. Nowadays, if we want to be as quick as possible, the shortest time to fly from Porto to Manila, it takes around 21 hours. If you take average connection, you can spend more than 1 day. But at this moment, using these new technologies, we are spending few seconds, even less than seconds, to communicate and share the knowledge. Well, after this introduction, I'm going to focus in the total laparoscopic hysterectomy in a systematic approach, trying to present every step of the procedure and analyze each detail of each step. And at the end, I will also share some cases that are more complex that surely we will face in our clinical practice, and we have to adapt our technique. Very old picture of the probably one of the first hysterectomies. That time they started by vaginal approach. This is one old video with several years showing Kurt Sam trying to perform the minimal invasive approach to hysterectomy. Look at the quality of this picture, not simple to see the anatomical details. In fact, he was suturing by laparoscopy. You see the uterine manipulator. He performed the subtotal hysterectomy. Now he was suturing the vascular pedicle. Anyway, there was some evolution in the image quality. And here in 1999, you can see this video of Harry Rich. In fact, he did a remarkable job. He described and published the first total laparoscopic hysterectomy. And here you can see that with a better vision, you can distinguish in a better way the different anatomical structures. And when you are, for example, closing the vaginal cuff, you can identify the uterosacral ligaments, the different fascia, anterior and posterior fascia, that was not simple to identify with the initial vision systems like you have seen before with Kurt Sam. Well, to succeed in total laparoscopic hysterectomy, we have to respect some conditions. We have to follow the ergonomy, and that I will present just afterwards. We have to have a set of instruments that should be the correct ones. And of course, you have to know the technique. The ergonomy, this strange word, means the study of the things that are related to the efficiency and comfort in the working environment. This is the picture of Harry Rich in the first laparoscopic hysterectomies, and you see the head and the body of him was not in the correct position. If he stays like this for a long time, surely he will have problems in the neck and in his back, what is not correct. This is another example. This is a picture of one of our training courses in Portugal. You see this trainee is training with the arms too high, and then he is not in an ergonomic position like I'm showing to you how it should be. There are several studies establishing the relationship between ergonomy and the laparoscopy, and this paper from the pediatric surgery focus in something that is very important. For example, the relationship between the arms and the trunk. You should have a 90-degree angle in order you are comfortable, you can be more efficient during your procedure. Also, the way that you look at the screen is very important. Your eyes should be at the same level of your screen in order you don't need to put your neck or your head in a bad position. You see here the 90-degree angle, and here you see that your screen should be just in front of you. These are simple things, but make the difference, mainly if it is a long procedure. If it is a long procedure, for example, here, the way that you take the camera on your hand, it's important to have a good vision, to keep comfortable. When the assistant is showing the surgeon the surgical file, then that is the correct way. Also, the position that you put the patient on the surgical bed for example, the relationship between the bed and the legs should be around 15 degrees. Just a few details that we should take into account before we start the procedure. This is the instrument set. As I said, we cannot make omelets without the proper eggs, without eggs. This is the basic. We need a grasper, we need a scope, we need trocars. You know, trocars, they make the interface between the exterior and interior of the abdominal cavity. You need the scissors, you need the needle holders. At least you will need to close the vaginal cuff, so you have to be prepared to suture by laparoscopy. If you are not skilled to suture by laparoscopy, don't go for TLH. You should train before how to suture correctly, and then you go for TLH. And you need a good bipolar instrument. And nowadays, as you will see during my presentation, we have very nice tools, very precise bipolar instruments that gives you the ability to dissect, to make the hemostasis in an efficient and safe way. For total laparoscopic hysterectomy, there is an instrument that is crucial. Some authors say that it may makes 50% of the TLH if it is well used, if it is used in the correct way. I speak about this uterine manipulator, very important. He has several tasks, but basically he offers a good exposition to the surgeon in the anterior compartment to see, for example, here the vaginal cuff. In the posterior compartment, you can see the uterosacral ligaments. It exposes you all the anatomical structures, the ligaments that you should approach when you go for TLH. In the European Society of Gynecological Endoscopy, we have published the key steps, the surgical steps of the total laparoscopic hysterectomy that you can take a look on it. It's available in our journal, Facts, Views, and Vision. But then I'm going, as I said, to describe each step of the TLH in order you realize at the end that is not so complicated. If you do correctly each step, you can make it in a good way. This is the coagulation and section of the round ligament, and here I will put in the beginning. It's very important, the work of the uterine manipulator. You see, the uterine manipulator is pushing the uterus to the right side of the patient, putting the round ligament under tension, and then you see that here there is this gray area, and above this gray area, it's where you should coagulate and cut your round ligament, because if you go medial to this gray area, you may find some vessels, some veins that can cause some bleeding. And of course, if you go lateral to this area, you can find the external iliac vessels that you don't want to reach. So you see, under tension, you go with your bipolar. As I said, nowadays we have good bipolars, and you see immediately the tissue becomes white. Why does it becomes white? It becomes white because of the protein denaturation. There is a electrosurgery that goes between the jaws of this bipolar instrument, and this electrosurgery causes the desiccation of the tissue. I mean, it removes the water from the tissue that is between the jaws, and at the same time it causes protein denaturation that puts the tissue white. Is the same that happens when you eat an egg. The albumin of the egg becomes white because of the albumin denaturation, the protein denaturation. You can see also a few bubbles coming out. You see the bubbles. The bubbles is the water that is coming out of the cells. And even if you don't have a good electrosurgical unit that measures the resistance between the jaws, measures the impedance, and when the impedance or resistance is maximum, It means that there is no electricity passing between the two jaws. When you have these machines, they measure, and normally they stop or they make a beep that tells you that the resistance is maximum, and then that you can stop. But even if you don't have these sophisticated machines, just looking to, using your eyes, using your brain, you see these bubbles coming out. When the bubbles stop, it means that there is no more water between the jaws. It means that you can go and cut in a safe way, because it means that there is no blood in between, and you should cut exactly in the same place where you coagulate, above the gray area, as I said. Normally, that is the Simpson artery that is in the base of the round ligament that goes around there, and you should coagulate it precisely and cut in an efficient and safe way. This is simply the first step. I think the first step reaches this area. This is the broad ligament, and here we already can identify the anterior leaflet of broad ligament and the posterior leaflet of the broad ligament. And then we go for the, but you see this small bleeding was coming from the Simpson artery. But you should go again with the bipolar. I have a video with a different device, but anyway, the principle is the same. We are using a sealing device, but you do exactly the same, coagulation and cut. I think you have understood. The difference is that with this device, you cause some sealing on the tissue, and there are advantages of it, but also to open the leaflets can be a little bit tricky. Anyway, just to show you this alternative. The second step is the opening of the anterior leaflet of the broad ligament. Remember, we coagulated and cut the round. Then we have these two leaflets, the anterior and the posterior leaflet of broad ligament. And then you wait a little bit that the gas infiltrates between the two leaflets, and then you will have this approach. Again, you see the job of the uterine manipulator. The uterine manipulator now is pushing to the right, but also pushing cephalad or cranially, in order we have this tissue under tension to make surgery, to cut. It's important that we always have our tissues under tension. If we want to use electrosurgery here, we should put this like a tent. You see, we are using this instrument that goes through the tent, putting the tissue like this, and then you go with your scissors using monopolar current, cut mode, and very important, the assistant can grasp the round ligament, helping to put the leaflet under tension, and then you go like this, using the monopolar scissors, using cut mode. I mean, pushing the yellow pedal if you have it configured in the right way, and then you go like this. You see, you should push the pedal before you touch the tissue, because you want to cause vaporization effect on the tissue. You want to cause the cut surgical effect. And then you have electrical arc that should be very small. So if you respect these electrosurgical rules, you can cut this tissue like you are seeing here, like a cold knife, and you go up to the vesicouterine or vesicovaginal fold. You can dissect a little bit more in order you can expose all the vessels around the veins, remember, and sometimes you can see even the uterine artery in this step that is beating. You should go up to the vesicouterine fold. Okay, I think you understand. This is another example with another devices. The principle is exactly the same. You see the CO2 going through the space, the assistant grasping the ground, opening the anterior leaflet, going down, and you can dissect, helping a little bit with this beautiful dissector and bipolar, and then you make the tent and you go in the same way up to the vesicouterine space. The third step is the fenestration of the broad ligament. There is some controversy about this step. Some surgeons say that it can be a wasting of time, but in fact, it is not. And you will see, you will feel it, because it gives us several anatomical and surgical landmarks that are very important. You see what we do, we fenestrate, we make a window in the posterior leaflet. Of course, we have to pay attention to some veins and vessels that can be around. You need to dissect sometimes. And then you have the window, and this window, there are some rules that we should respect. We go with the two instruments, and we should open the window parallel to the IP ligament or parallel to the uterus, horizontally or vertically. If you want to leave the ovaries, it's better to make the fenestration parallel to the uterus. If you want to remove the ovaries together with the uterus, it's better that you open the window parallel to the IP ligament in a transversal way. So after making this fenestration, you know that we will enlarge this fenestration. We know that the vessels are medial to the fenestration, and we know that the ureter is lateral to this fenestration. We enlarge carefully. This is not a simple case, but anyway, even in more vascular cases, we have to follow the rules. This is a case that you can see in a better way the posterior leaflet, but again, you enlarge your fenestration. Here, the hemostasis should be very careful, and then you are sure that the ureter is lateral and the vessels are medial. It gives you safety in your approach to the uterine vascular pedicle. But I will show you afterwards the advantages. This is another example, the fenestration. Pay attention when we do it. Sometimes you have the bowel just behind. And also I want to show you that the ureter goes in the posterior leaflet of broad ligament. Always remember that. And the ureter is very close to the uterine artery in that area. But we will go into detail about it afterwards. This is the fourth step, the coagulation and section of the infundibulopelvic ligament. If you want to remove the ovaries together with the uterus, or the uterovarian ligament, if you want to leave the ovaries back. This is an old video. In this time, we did not perform the opportunistic or prophylactic salpingectomy, but nowadays we do it. I will show you some videos of it. But here is what I wanted to show you. If you have the fenestration, if you have the window, you can go with your instrument and you can delimitate exactly the tissue that you have to coagulate and cut. This is the uterovarian ligament. You have all this tissue, and with the fenestration, you know that you can coagulate everything here. No worries about the ureter, no worries about other structures that you can damage. So it's relevant, and from my point of view, is one of the good benefits of making the fenestration. And then you go with your bipolar. Remember what I said, look at the screen, see the bubbles, see the water. This is the coagulation of the uterovarian ligament. You should cut exactly in the same place that you have coagulated, and then precise hemostasis. Sometimes you need to go with your instrument and compress the tissue to avoid any bleeding. And then you go, small cuts, slowly, and you cut the uterovarian ligament in this simple way. And no worries about the ureter, because we know that it is away. This is what we do nowadays, the opportunistic salpingectomy. We leave the ovaries, but we remove the uterus plus the tubes, and here we use the different techniques, and we go very close to the tube in order we preserve the vessels and the irrigation that go to the ovary, because one of the problems related with this opportunistic salpingectomy was the risk of impairing the ovarian irrigation. So if we go very close to the tube, we decrease that risk. I mean, we should preserve as much as possible the mesosalpinx to keep the ovarian irrigation, to keep the ovarian function. Another example, opportunistic salpingectomy. You can use other devices, but as you have seen with the reusable bipolar, you can do the job in a very efficient and good way. This is just to show you that we can also use a different approach, but the principle, the surgical procedure, it's exactly the same. When we want to remove the ovaries together with the uterus, we have to coagulate and cut the IP ligament. And then it's very important that your assistant grasps the tube or the ovary, but the tube works very well to put the IP under tension. And if you do like this, you control the distance between the IP and the ureter. Remember that the ureter goes just medial to the IP. And then if you apply some tension like we are doing now, we separate the IP from the ureter, and from this area where goes the external iliac vessels, like the external iliac artery and the external iliac vein. We can use a sealing device, but also you can use a bipolar that works very, very well, and it's a reusable instrument. The fifth step is the opening of the posterior leaflet of broad ligament up to the cervix. And this step is relevant because of two main things. If you free this posterior leaflet, you gain more mobility. When you are mobilizing your uterus with the uterine manipulator, you can push your uterus more cephalate, more cranially, and then if you can do it, you increase the distance between the uterine vessels and the ureter, and also you can expose better the uterine vascular pedicle. So when you will go for uterine vessels coagulation, if you have a better exposition of the vessels, you can be more precise and more efficient in your vessels coagulation. Another example, don't regret to spend some time on this step because you gain safety. And if you can isolate better the uterine artery, you can be more precise in your coagulation approach, and then you reduce the risk of complications. Before you go to the coagulation of the uterine vessels, it's advisable to open the vesicovaginal space, to push the bladder down, because if you push the bladder down, you also increase the distance between the ureters and the uterine vessels. And for this, I want to stress on this picture on the left, it's necessary that your assistant grasps the bladder, not only the peritoneum. It's important that the bladder comes anteriorly, and then if the bladder is pulled anteriorly, you see, the surgeon shows the bladder to the assistant. The bladder is there. The assistant grasps all the tissue, not only the peritoneum, and then you can find your plane, you follow the bubbles, and also it's relevant here the work of the second assistant with the uterine manipulator, because here you have the cuff of the uterine manipulator that is showing you where is the vagina, and then you see these bubbles, you see this space. You just need to follow the bubbles, make your dissection, and it's important to distinguish. This is vaginal tissue, this is the bladder tissue. the bladder tissue has some fat attached. And remember that the fat belongs to the bladder. It's the same as in the posterior compartment. In the posterior compartment, the fat belongs to the bowel. In the anterior compartment, the fat belongs to the bladder. And then you can pull down or push down the bladder, and the ureters also go a little bit down, and you gain some safety when you go for uterine artery coagulation. Another approach, but the thing is the same, using different device. Here you can go centrally. There are some situations that you cannot go this way if there are previous C-sections, or if there is endometriosis in the vesico-uterine space. It's better to approach laterally and try to identify the limits of your bladder laterally and anteriorly, and then you gain some safety in your dissection of the vesico-uterine or vesico-vaginal space. But anyway, the principle is the same, just I want to show you. Yeah, this is a nice video, this is a nice case where you can see very easily the limits of the bladder. You see, this is the bladder, this is the vagina, you can see the boundary there, but unfortunately this is not so common. So like this, you know that you have to open there, you coagulate that area, you go dissecting the tissue gently using the dissector. Remember what I said, it is a strong dissector, and the tips are not sharp, so you are safe in your dissection approach going in this area. Remember the tissue of the vagina in comparison with the tissue of the bladder, different tissues. If you become familiar with these tissues, you increase the safety of your approach. The seventh step, as I said, is the coagulation and section of the uterine pedicles. I think this is probably one of the most dangerous steps. I mean, probably one that we have to pay more attention, because if we have a bleeding there, it can be difficult to control, and then the ureter is close by, and if you try to coagulate everywhere without having a good vision, you can cause a thermal injury in the ureter. That's why before I said that it's important that you have a good exposition of the uterine artery. And many times you see it beating, and you should go with your bipolar, trying to skeletonize the uterine artery and sometimes the uterine veins that are just behind, and you can grasp all the vascular pedicle, but be patient. Sometimes you need to coagulate in different places, 1 millimeter, 2 millimeter above, or 2 or 3 millimeter below. Remember the principles of the bubbles. Wait that the bubbles stop. It means that there is no water between the jaws of your bipolar. And then small cuts, you see there is the uterine there. Now you see the uterine artery, there are the uterine veins just behind, and you should continue carefully, be patient in this step, because if you have a bleeding, sometimes also what happens is that the uterine artery tip retracts, and it goes into the parametrium, into the cardinal ligament, and then can be very difficult to coagulate it. And the ureter is there, and easily you can make a burn in your ureter, and you can have a fistula afterwards. Another approach, the principle is the same. You see here we can cut the posterior leaf of broad ligament to have a better exposition of the uterine artery that is just there, and then you go with your instrument, your bipolar, and take it in a precise way. Eighth step is the vagina opening. is something simple if you know the principles of electrosurgery, how to use a monopolar current, cut mode, coagulation mode. The work of the uterine manipulator is also very relevant because it exposes you the vaginal cuff and tells you where you should open the vagina. I said that you should know about electrosurgery in order to avoid a lot of smoke. I recommend you to use cut mode and try to apply the monopolar current in a small surface. Don't take a big surface. It's better that you make a small cut with your monopolar hook than take a lot of tissue because you cause a lot of smoke. Your system can be with the suction device and with the small movements can aspirate a little bit the smoke. If you don't have a good vision in this step, don't continue. It's better to wait some time. It's better to clean your vision, to check around if there is any bowel loop, if there is any important structure, because as I said, in this step, there is a lot of steam, a lot of surgical smoke that can impair your vision, but with practice and with training, you know how to decrease it and how to open the vagina in a correct way. The ninth step is the uterus removal and can be challenging in some situations, mainly if the uterus is big or no vaginal deliveries before, and then can be time consuming to remove your uterus, and sometimes you need to cut the uterus in smaller pieces, and you can do it intra-abdominally or you can do it vaginally. We are doing more and more vaginal morcellation for big uterus. Many times we also put them inside the bag. We pull them through the vagina and we morcellate inside the bag. And you can do also intra-abdominally using the Chardonnay morcellator that you probably have seen before. The vaginal closure, it's the last step, and you have to do it in a correct way, because if you don't do it in the correct way, there are the two risks mainly. There is the risk of vaginal cuff adhesions, and there is also the risk of vaginal cuff prolapse after the procedure. So it's very important that you know how to make the suture by laparoscopy. You can use an extracorporeal approach like in this case, or you can do an intracorporeal approach. It's very important that you join the mucosa, that you join both fascia. You have the anterior vesicovaginal fascia and you have the posterior rectovaginal or denonvilliae fascia, and you should join them to restore the endopelvic fascia. And in many cases, it's recommended also to join both uterosacral ligaments to do what is called the Hymakol or modified Hymakol approach to decrease the risk of vaginal cuff prolapse after the procedure. It's of course necessary to have good needle holders, and these ones are probably the best available. You can do, as I said, intracorporeal. For intracorporeal, you need a shorter thread, 15-20 centimeter thread is enough. You should join the anterior and posterior mucosa. Take the fascia. You see, this is the anterior vesico-pubo-vaginal fascia. You can take now the left uterosacral ligament, then you will take the right uterosacral ligament, and in the same stitch, you see the right uterosacral, in the same stitch, you can connect all these structures, trying to restore the pericervical ring and keep the location and the support. Just to show you this detail, this is the final aspect of your ovaries. You see, the fenestration and the window that we do, remember, if we want to leave the ovaries, we should make the fenestration parallel to the uterus. And if we do like this, the ovary stays in the correct position after the hysterectomy. If you make the fenestration parallel to the IP ligament, there is the higher risk of having ovarian torsion or a longer pedicle in that area, and you also increase the risk of having cysts. So this is the final aspect that I want to underline to show you the importance of making the fenestration in the total laparoscopic hysterectomy. For closure, there is also these barbed sutures that can help a little bit, but anyway, you have to be very careful, trying to avoid any barbs out of the incision closure, because if the barbs are exposed, some bowel loops can be attached according to some case reports published. Then you have to be careful, but anyway, it's a different approach. Can be nice because it can save time to the surgeon. But anyway, we have to know how to suture by laparoscopy. If we don't close the vagina in the correct way, we can have situations like this, vaginal cavitations. And many times you can have bowel loops that go through this way and can be urgent or emergent situation. That's why you should invest time to make the vaginal closure. I know that at the end of the procedure, sometimes the surgical team can be a bit tired, but don't relax in this moment. The closure of the vagina is paramount importance to avoid this situation that can be really bad for those women. Finally, I will share with you some more difficult scenarios that, for example, in our center, we are treating more and more as a referral center associated with a large uterus with fibroids that change the anatomy. It can be in broad ligament or cervical myomas. These ones can be difficult, but anyway, there are tips and tricks to make it in the correct way. Then you also have the possibility to, I will just here, wait 1 second. I will just here make here one thing, because I think okay. If you have a severe adhesions associated with endometriosis or pelvic inflammatory disease, also we have to keep in mind that sometimes if you have a big uterus, you have a reduced space, you have less mobility, the anatomy can be changed by the endometriosis, by inflammatory disease, the bleeding risk also is increased, and the tissue extraction sometimes can be challenging, like in this situation, very big uterus. We have to morcellate it using the shadow knife, and we are cutting the uterus in small pieces. Of course, nowadays we have to be sure that it is a benign pathology, but to show you that we have alternatives in these challenging situations. For the mobility, and this is why I presented to you this uterine manipulator. There are several in the market. For example, I remember the Mangeshikar and the Keckstein uterine manipulators are very good. They work very well. I like both of them, but we are used more with this one because they, even with the big uterus, it is quite strong to mobilize the uterus, to make the anteversion, the lateral and stabilization, and even the elevation of the uterus. It is very strong. Of course, it looks probably too strong, but we should have a tool, we should have a uterine manipulator that works for every scenario, from the simple one to the most difficult ones, and then it works quite well. We have sometimes the reduced space, and for that we have to play a little bit with the trocars location. We know that laparoscopy is a kind of virtual surgery. We see what the scope shows to us. So if we move our scope a little bit upwards above the umbilicus, the picture becomes better, and we have a better vision of our surgical field. Sometimes we can also change our scope for from a 0 degree to a 30-degree scope. It can be helpful to see the lateral parts, the lateral compartments, and sometimes we can use some medicines to reduce the size of the uterus before the surgery. Two important structures in the pelvic side wall that I want to stress is the ureter. Remember that we gynecologists are the biggest predators of the ureters, so we have to always keep this in mind and try to avoid to injure the ureter. And in many countries, the litigancy issues and medical legal issues related to the ureter are very difficult for the doctors, for the surgeons, so we have to pay attention on it. And the best way is to always identify where is the ureter, because if we know where is the ureter pathway, of course we will try to avoid to cause any injury. And this is the uterine artery that crosses above the ureter. Remember the bridge and the water under the bridge. And you see here is the uterine area where we make the coagulation. The distance normally is between 15 millimeters up to 20 millimeters, so it's very close. So if you have a bleeding there, if you cannot control your uterine artery when you coagulate, many times the uterine artery retracts a little bit and becomes very close to the ureter. That's why you have to be very careful when you make the uterine coagulation. Sometimes you have this shape of the uterus, remember the cervical fibroids, and in these cases, for example, we go to the origin of the uterine artery and we put a clipping there, and then when we approach to the isthmus, we reduce the risk of bleeding. Paying attention to the ureters always, of course, and parametrium. Sometimes for hysterectomy we find these scenarios, and again we have to be patient making the adhesiolysis, the bowel and omental adhesiolysis, up to we have a good vision of the uterus that we are looking for. This is a uterus with a myoma, and you see at the end you have the uterus free to go for your procedure. And sometimes if there are big myomas, it's helpful to remove the myomas first and then remove the uterus, because if you remove the myomas first, you get a better exposition. This is another case full of adhesions, patient with previous colectomy due to colon cancer. Again, follow the bubbles, be gentle, slowly. Sometimes you have to change your trocars placement, you have to approach from the right. Anyway, just a few examples, but this is what I was telling before. If you have a difficult access to the isthmus, for example, if you have cervical fibroids, or if you have the shape of the uterus with an enlarged isthmus, it's recommended to coagulate the uterine artery at the origin, and you can have this approach or you can have the anterior approach. We are very familiar with this approach, trying to identify the uterine artery at the origin, paying attention to the ureter and following the umbilical artery. This is another example of a broad ligament fibroid. Of course, it is blocking our access to the uterine artery, but in this case, we recommend to remove first the fibroid. paying attention to the vessels, the big vessels that go there, the iliac external vessels, paying attention to the ureter, and on the other side, in the medial side, paying attention to the uterine artery. You see, it happens, and we have to be prepared for this situation using a strong dissector, a precise bipolar instrument. When you are approaching this, be careful. Again, don't forget the ureter that is very close. After C-section can be also challenging and demanding. This is an example after 2 C-sections. It's sometimes not simple to identify the bladder limits. You can use different techniques. You can fill your bladder with saline. You can fill your bladder with CO2. You can fill with methylene blue. But anyway, you have to try at the beginning, separate the uterus from the abdominal wall, in this case, keeping in mind that the anatomy is completely distorted. This is the right round ligament that you should try to restore the anatomy before you go for hysterectomy, because you know the anatomical landmarks related to the round ligament. Anteriorly, you have the bladder. Posteriorly, you have the tubes and the broad ligament, and laterally you have the external iliac vessels. And in some situations, when you have this anterior compartment blocked, can be helpful to secure the blood supply, as I said, to clip the uterine arteries, and then you complete the rest of the hysterectomy, and then you approach laterally and anteriorly, as I said before. This is another example showing you where is the ureter, paying attention. You see, if you have a good light, if you don't have any bleeding, the shape and the picture of the ureter is very typical. This is another situation of endometriosis infiltrating the cardinal ligament on the left side and the left parametrium. We do the same as we do for radical hysterectomy. We try to remove the parametrium infiltrated by the disease, keeping attention to the ureter. We go through the ureteric tunnel, trying to respect the ureteric adventitia, and then we go up to the vesico-uterine space, to the abuki space, trying also to preserve all the irrigation and innervation of the bladder. I put this example because it happens mainly in endometriosis cases, that there is indication for hysterectomy plus oophorectomy, and you see many times at the beginning you don't find the ureter, the ovary, and you see, if you are careful in your dissection, look at the beginning, you don't see anything, just a mess of inflammation, of endometriosis, but then you go slowly, blunt dissection, using your bipolar, trying to apply some coagulation, apply some traction, and then you can identify the ovary. And inside this ovary, there was also endometrioma that I will show to you. This is important because it's very common in endometriosis surgery, the ovarian remnant syndrome, because sometimes we don't remove completely the ovary and they continue to produce estrogens. You see the endometriosis, the endometrioma that was inside, and at the beginning was not easy to identify. And to finish this last video about some situation that we can find, there is indication for hysterectomy, and we go with the scope and we don't see any uterus. We just see a mess of bowel loops. Finally, the second assist was moving the uterine manipulator, and we can see the uterus finally. but full of adhesions, completely frozen pelvis. But as I said, we have to be careful, we have to be gentle, trying to identify the anatomical structures, the anatomical and surgical landmarks to survive in this challenging and demanding scenario. This is what I wanted to say. Thank you very much for your attention. Please do not hesitate if you have any questions. Thank you very much.
Thank you very much, Professor. That was a very, very comprehensive lecture. And I know there are so many questions in the poll. We're going to entertain questions later. But for this time, I would like to call first on our poll questions. There are several questions that we would like to pose to our audience. You're given, this is not a very difficult question. Can you have the poll question, please? This is probably just 4 or 5 questions. All right, the first question is a yes or no question. Systematic approach, okay. So total laparoscopic hysterectomy is performed in my hospital or in my center, a yes or a no. Could you please answer? You can click on the screen. Yes or no? And then the second poll question, I perform total laparoscopic hysterectomy. So currently we have 285. Wow, we have 285 participants, and we would like to see how many of these participants do perform total laparoscopic hysterectomy. The third question is, yes, if you have performed total laparoscopic hysterectomy, we would like to know how many have you performed? A, less than 2, less than 10 cases, more than 10 cases. We would like to see that. It's quite obvious. I'm trying not to wear my eyeglasses. All right, so do we still have poll questions? Okay, though. All right, so maybe can we see the answers to these poll questions? Lawrence? Have our participants clicked? We would just like to know the profile of our participants. Almost 300 participants. Wow, okay. Almost 300 participants. Obviously, 81% have performance of TLH in their hospital or in their center. And yes, 71% of our participants, Professor, are doing the total laparoscopic hysterectomy. And most of them has done 50-50. 50% has done less than 2 cases, and 50% has done less than 10 cases. Wow. Okay. So I'm pretty sure we're going to be bombarded with a lot of questions. Do we have some more poll questions here? No more, Lawrence? Okay. So thank you very much for these results. No? Yes. Okay. Somebody raised the hand. Okay. All right. So no more poll questions. No more poll questions. We will look at the questions in the Q&A portion later. But after these poll questions, we have invited the past president of our, do we still have poll questions? Can I see the next slide, please? So we're going to look at the question and answer first. Okay. So there is a question here. We're going to ask Professor the question now. Yes. Yes. All right. No more. So are we opening the floor already for the Q&A, or were we going to wait for Dr. Tan Cardoso first to react? Yes. Okay, but before we go into the question and answers first, okay, so that both of our professor and Dr. Tan Cardoso will be answering the questions, we have invited somebody to react to the lecture of a professor. He is the past president. Can I have the slide, please? He is the past president, the immediate past president of the Philippine Society for Gynecologic Endoscopy. He has been introduced adequately. We fondly call him Dr. Tantalizing Eyes. Ladies and gentlemen, please welcome my former boss in Amang Rodriguez Memorial Medical Center. Please welcome Dr. Herman Tan Cardoso. Dr. TC, floor is yours.
Yes, thank you, Dr. Alinsuela, for that very gracious introduction. It's nice to know that there are many of us now doing laparoscopic hysterectomy. We don't have a very good census at this time, but maybe Prudence or Tonette, we have to start asking or making census on the procedures. So we have seen and watched a very impressive presentation of Professor Ferreira, presentation of the systematic laparoscopic hysterectomy and some difficult situations. He shared with us the masterly executed 10 steps of total laparoscopic hysterectomy with a lot of tips and tricks, a lot of pointers, and also with how to perform difficult laparoscopic surgery when there is alteration of the pelvic anatomy, secondary to endometriosis, infections, severe post-op adhesions. He showed us how to untangle a frozen pelvis and how to execute adhesiolysis as the first step in hysterectomy. Because when we have such an anatomic distortion, the first thing that we should do is to restore the normal anatomic relationships of the organs in the pelvis so that we get oriented and therefore we avoid incurring complications. We have seen more than enough of surgical techniques, laparoscopic surgical techniques. So I don't have to show you any additional surgical videos. So I will talk about philosophical concepts and some theoretical aspects of laparoscopy. My slide is not moving. Wait a minute.
Sir, if you're using a MacBook, you can just press the arrow to the right or the arrow down.
No, I'm using Samsung, HP.
Or page down, or you just press page down. HP, happy people.
Yeah, it's not working.
Okay, so
maybe I should stop sharing and use this one. So I maybe use this. I have to use this portal. So first of all, let me speak about a little of the surgical routes of operation. With regards to abdominal hysterectomy and maybe abdominal operation for that matter, we have two major routes classified as laparotomy, the open laparotomy, and the minimally invasive surgery or minimally invasive technique, or we call it minimal access surgery. And with this minimal access surgery, we have the vaginal, we do vaginal hysterectomy, or we can even operate on the adnexa through the vagina. And we have mini laparotomy. It's a 4 to 5 centimeter incision on the abdomen to perform abdominal operations. And we have laparoscopy, also robotics, and the newest technique, which is NOTES, natural orifice transluminal endoscopic surgery, where we make use of the vagina as the entry point, using basically the technique of laparoscopy. There is also combination of these access techniques like mini-lap assisted vaginal hysterectomy and also laparoscopic assisted vaginal hysterectomy. Why are we talking about laparoscopic surgery or laparoscopic hysterectomy? Well, laparotomy, open laparotomy has been with us for so many years, maybe thousands of years, and the results are excellent. Over this time, we have developed perfect techniques, or maybe nearly perfect techniques, accessing the abdomen or the pelvis through an incision in the abdominal wall. And we are happy with it. Then why we develop minimally invasive surgery? The goal now of modern surgery has focused not on the surgical techniques, because we have developed perfect techniques already. So the goal now is to give the patient good surgical experience with the use of less aggressive surgical techniques. And with these techniques, patients would have fast recovery with less scarring, less pain, and therefore they have improved quality of life for the patient. So minimally invasive surgery has taken the pain away from the patient. It made them experience a better recovery, but the pain was given to the surgeon. It made the surgery more difficult for us. We have to train and retrain. There are many factors to consider before deciding on appropriate surgical route. With those many choices, we have to first understand the individual patient's anatomy and underlying disease process, which means that if we have vaginal prolapse, there's no need to do the surgery abdominally or laparoscopically. We approach directly through the vagina. Another thing to consider would be the expertise of the surgeon. The equipment availability, of course, if you don't have the towers, you have to do the procedure abdominally. You also have to consider the contraindication of the proposed route, because there are contraindications to doing laparoscopic hysterectomy, and there are indications too to doing laparoscopic hysterectomy. So we would ask ourselves, is abdominal hysterectomy obsolete with these many routes to perform the surgery through minimally invasive approach? The answer is not yet. There are still many conditions that need to be operated transabdominally. To perform a safe laparoscopic hysterectomy, there are many requirements that we have to observe, we have to follow. These are deep knowledge of the pelvic anatomy. You see, although we have the same structures in the pelvis, when we perform the different routes, These particular routes have their own anatomy, so to speak. For example, when you're operating transabdominally or through open laparotomy, your position is facing the structures perpendicular. We are used to that because we were trained to be abdominal surgeons. But when you learn laparoscopy or when you're learning laparoscopy, you will be facing the structures parallel. And that would somehow give you new orientation. So that the way that you see these structures becomes different. And when you are performing vaginal hysterectomy, you're looking from below. Like if you're learning notes operation, your orientation to the pelvic organs would be parallel from below. So to perform safe and safe surgery, you have to have skilled assistants for laparoscopic operation and for other minimally invasive approaches. For abdominal hysterectomy, you can have the nurse as your assist just to do some retractions. You can ask an intern to assist you. But with laparoscopy and with the other techniques, you need a skilled assistance. You cannot perform the operation by your own self. Another requirement would be the availability of basic instruments. You must have a properly functioning tower with clear video. It would be very difficult to perform the operation with an unclear picture. You might be interpreting the anatomic relationships and the anatomic shape wrongly within an unclear video. We often use 0-degree laparoscope, but sometimes there is a need to use 30 degrees laparoscope. As lectured by Professor Ferreira, the uterine manipulator is very relevant, very important when it comes to laparoscopic operations. I will discuss this further in my next slides. And you have to have a good knowledge of the electrosurgical device to avoid or prevent energy-related injuries. Surgical skills, yes, as mentioned again by our speaker, you need to have that skill of suturing to close the vaginal vault. During our early days in performing hysterectomy, we closed the vault transvaginal. We didn't have the needle holder. So we had to close, and we also don't have the skills, the suturing skills, and so we closed the vault transvaginal. It is important then to have the appropriate instruments, and there are 3 basic instruments that you need to perform laparoscopic hysterectomy and other laparoscopic operations. You need the bipolar forceps, a scissors, and retracting forceps. But with these new energy devices, it made the performance of laparoscopic operation easier. These instruments would coagulate and at the same time cut. You don't need anymore to be changing your instruments frequently. With the operating room setup, you cannot just stand at any side of the patient. Again, as it was discussed by Professor Ferreira, there is ergonomy. There is ergonometric ergonometric relationship when performing laparoscopy or any other operations. The ergonomy in open abdominal operation is different from the ergonomy in laparoscopy. Ergonomy, as explained, means the interface between the operator and the machine. And with ergonomy, it makes us better perform. We optimize the use of the machine or the device, and it makes the procedure safety. As I've mentioned, very important would be your first assist. If you are right-handed, you stand to the left of the patient so that your right hand would have more freedom to move. And the first assist would stand to the right of the patient. The first assist should know how to operate the camera. And he or she should know how to make use of the hand instruments. Operating the camera is not very easy. If your assistant cannot focus the camera to the right angle and to the right distance, it would be difficult for you to perform the act, because there would be disorientation in the depth. We don't have a good depth perception when we perform laparoscopy. Equally important would be the second assistant who sits between the legs of the patient. It's the second assistant who performs the manipulation of the uterus with the use of uterine manipulator and with the colpotomizer. As discussed again by Professor Ferreira, this is a very important device to manipulate the uterus. It directs the uterus to the left, to the right, up. It can pull down the uterus, and you can push the uterus up, caudad, to bring out the structure that you want to work on. During our first attempt to perform laparoscopic hysterectomy, we did not have any manipulator. And it was difficult to identify the location, the uterine vessels, and the bladder, so that this colpotomizer would facilitate identification of important anatomic structures. It is important to outline the cervicovaginal junction, where you would amputate the cervix or the vagina, and it makes dissection of the bladder easier. If you see this yellow thing, this is the yellow tube. That's the first colpotomizer that we had with that metal elevator. This tube colpotomizer came from India, and it made us perform the hysterectomy easier than without the colpotomizer. There are many types or many kinds, different kinds of colpotomizer in the market. They come in different shapes and with different mechanisms. Another important role of the colpotomizer, it would show you where the uterine vessels are. This is very important. And when the colpotomizer is pushed to one side and caudad, it pushes the ureter away from the uterine vessels. Another thing that I would want to emphasize is the technique shown by the professor in the dissection of the broad ligament with steps 1 and it's steps 2 and 3. If you perform hysterectomy going straight to the broad ligament after dividing the uteroovarian ligament and the tube, and you go up, you go directly through the broad ligament, coagulating and cutting. You know, when you do a series of that step, sometimes it can bring the ureter near to, it can bring the ureter medially, and that puts the ureter in a serious position or in a critical position for injury. It comes close to the uterine vessels. So it is important that you dissect the anterior and the posterior leaves of the broad ligament separately. And when you cut that ligaments, the broad ligaments, the ureter would fall back away from the medial, and that brings it away from the uterine vessels. There is slow adaptation of laparoscopy in the Philippines because many hospitals still don't have the tower, and there are few trainers. We started to perform laparoscopy many years ago, but we really have not succeeded, or we have not reached the peak. There are only few institutions accredited by the PSGE. In fact, there are only 3. But there are other institutions doing laparoscopy as part of other subspecialties. And those institutions are recognized by the PSGE. Another thing why we have few cases, laparoscopy, particularly laparoscopic hysterectomy, is that we share the cases with the residents doing general gynecology. We have been integrating laparoscopy in the residency training program, but this was interrupted by this pandemic. We were supposed to fully integrate endoscopy into the residency training program this 2020. And the exit competency required by the PSGE to be recognized or to be a fellow of the society is ESRE level 2. That is performance of simple adnexal operations. For laparoscopic hysterectomy, you have to undergo another training. And the PSGE has this program, the TLH Sprint. This is the total laparoscopic hysterectomy mission, wherein we have 8 trainees. Again, the program was interrupted by this pandemic. But it's nice to, I'm happy to learn from the statistics that we had today that many of our colleagues are not doing hysterectomy. So there are ways to do there are ways to do hysterectomy. We can have the open and the minimally invasive. And there is a way to do it well. With the proper selection of patient, we can perform very safe procedure. And there's a way to do it better when the surgeon is well trained with the different approaches. Before I end, let me share with you my favorite quote. You don't need to be better than anyone else. You just need to be better than you used to be. So my dear cool colleagues, let us grab every opportunity to train to be better surgeons. Thank you very much. And back to you, Annabelle.
Sir, thank you. Thank you very much, Dr. TC, Dr. Tan Cardoso. Okay. So we now go to the questions. We would like to entertain now the questions. So can we, okay, the first question here, Dr. Professor, I know that you have answered some of the questions, but we would like to probably hear it from you, answered live. So the first question here posted was coming from Dr. Richard Cacho. He's a gynecologic oncologist. His question is, what is the advantage of cutting the round ligaments first rather than coagulating and cutting the IP ligament first? I know you've answered it, Professor. Thank you.
Now that is a very good question, and I want to answer in a pragmatic way. I think the most important is to make a good suture, is to restore the anatomy, as I said, to restore both fascia, the anterior, pubo, cervical, vesicovaginal fascia, and the posterior non-villier or retovaginal fascia. We have to join both fascia, we have to join the mucosa. We should also follow the modified IMACOL technique, trying to join the uterosacral ligaments. The type of suture, I think, is one that we feel more comfortable. There are some papers and studies that the extracorporeal can be a good choice because we control better the tension that we apply on the tissue and on the suture, but intracorporeally you also can do it in a correct way. There is also a controversy concerning the type of thread that we should use, if we should use polyfilament or monofilament. The monofilament can be better because it slides better through the tissues. But anyway, the barbed suture also is an option. We are not still very familiar with it in our center, but as I said, to use the barbed suture, we have to avoid to leave any barb exposed in order to avoid any bowel loop to be attached on it. But if you use it in the correct way, I think it's a good approach and you save time. But anyway, in our training center, in our hospital, we try to go for the intracorporeal because it's a way that the surgeons train the intracorporeal suture to close the vaginal cuff and to join the uterosacrals, to join all the structures, to restore the pericervical ring. It has worked well, we have good outcomes and we are happy with it. But I don't know if in the future, now we are using the barbed suture, we will change our mind. But the most important is to have a good anatomical outcome.
Thank you very much, Professor.
Annabelle?
Partner?
Annabelle?
Sir? Yes, sir.
Yeah, may I ask a important trick from Professor Ferreira?
Yes, sir, of course.
Yes, Professor. We both agree that colpotomizer and uterine elevator is a very important device in laparoscopic hysterectomy. How do you perform hysterectomy in a patient who has a very narrow vagina wherein the device cannot be inserted, or maybe in a virgin?
Yeah, that is
how do you give
a
a
good
landmark for that?
That is a good question. We have cases that is not possible to introduce the uterine manipulator. We speak about version, we speak about very old ladies for endometrial cancer with vaginal stenosis, and also we operate some malformations, mullerian malformations, and we have to adapt. What we do, we use the screw, we use the myoma screw to mobilize the uterus as we do with the uterine manipulator. And sometimes if there is room to make a breast valve in the vagina, we use it to identify the vaginal cuff. But of course, it's a complex procedure. I think it should be performed after some experience. But the principles are the same. But we do we use the screw. The screw works quite well. We need many times an extra port for the screw, and it's possible to expose the anterior compartment, the posterior compartment, and sometimes we have to change the location in the uterus where we put the screw. But it works. It works for oncological purposes, for cervical cancer. We also are using it. A screw for for oncological purpose, a screw with a small tip, not very deep, in order do not go inside the uterus.
So
Thank you.
Usually this screw is 5 millimeter or 10 millimeter in diameter?
5
millimeter. Right.
5 normally a 5 works well. If it is a very big uterus, if the uterus is soft with adenomyosis, sometimes you need a 10 myoma screw. It's true. We have both. In our instrument setting, we have the 5 and the 10 instruments, but most of the times the 5 it's enough.
Partner, Nay? You have questions?
Professor, although I think you've answered it in the chat, in the question and answer box, it would benefit most of our listeners. So maybe we can answer the question regarding what are your choker placements for your TLH?
I didn't get the question. The question is?
What are your choker placements for your lap hysterectomy?
Yes. That is very important. I mentioned a little bit in my talk in one slide. It depends on the size of the uterus, but if it is a regular size, I put the optical trocar inside the umbilicus, not around or out of the inside, because the umbilicus is a natural scare and is the thinnest part of the abdominal wall, and is the safest and cosmetically the best way to go through. And I put 3 ancillary trocars. I put 1 central trocar suprapubic, in a distance between 8-10 centimeters below the optical trocar, but not too low because we can go through the bladder. And I use 2 lateral ancillary trocars on the left and on the right. And those ancillary lateral trocars should be 3 centimeters away from the anterior superior iliac spine, in a line that connects this anterior superior iliac spine and the umbilicus. So 3 centimeters away from it, following this line on both sides, is where I put, because we have to pay attention to the inferior hypogastric arteries that go a little bit medial to these placements I just said. But we have to be careful, because if we make an injury on those vessels, we can have a big bleeding in the beginning of our procedure, And remember that the inferior hypogastric artery is a direct branch of the external iliac artery, so it bleeds.
Thank you very much,
Yeah.
Professor.
May I add to that?
Yes, sir. Yes, Dr. TC.
Yes, if you observe, these Americans and Europeans usually place their ports medial, the way you do it, Professor. But for Asians, they do it ipsilateral.
I know.
And I asked why. Why is that? It's
No,
because Asians are smaller. They have shorter arms.
no,
That's
no, no,
why they
it's not.
place it ipsilateral. Yeah.
No, 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 it's not. It's a school. It's a school. For example, in US, it was Charles Koch that introduced the. It is related also with the suturing techniques, with all the training and courses that we do. The ipsilaterally, from my point of view, and according to what I read, and according to my experience, ipsilateral, I think the learning curve for suturing may be shorter, but this is controversial. We can discuss it in another webinar about. But the learning curve is shorter. It probably is a little bit more ergonomic for right-handed people to make it ipsilateral on the right side. But there are also some limitations. If you are suturing ipsilaterally, or for example, on the right side, and if you have a big uterus and you need to approach on the contralateral side, I mean, for example, in the left side, it can be very challenging, and you need to make an extra port on the other side to follow the same technique of ipsilateral. But anyway, both approaches, I think, are okay. As I said, if we have a big uterus, sometimes we need to move upwards the optical trocar and put the trocar in a subxiphoid location in order we have a angle vision offered by the scope that gives us a larger surgical file to approach the larger or the bigger uterus. But in my school in Europe, the Clermont-Ferrand school is like this, and we are happy with this approach. But I also learned the ipsilateral approach because I did training in US. Also, I did training in India, with Silesh and in other centers. But I think the central suprapubic approach gives us more versatility to work on both sides of the pelvis, and but it's a matter of training or a matter of school, and I also became happy with the ipsilateral.
I think at the end, I think it boils down to whatever is the surgeon is comfortable with. Whatever, yes, ergonomically, if you're happy with what you're doing right now. And I think the second thing is the view. There should be a maximal view. As long as you have a very good view in whatever you're doing, then you can continue. So I hope, Dr. Cacho, we were able to answer your question. There's another question here from Dr. Judith Galang Perez. She was asking, what adjustments in exhaust system setup have you made presently to address the theoretical risk of COVID dissemination? Maybe
yes,
because it's not.
That is an important issue at the moment. We started to use the smoke evacuation filters. Any smoke that we need to remove, for example, at the end of the procedure to evacuate, we use the filters that many companies produce it, and it works quite well theoretically, because there is no proof at the moment that the coronavirus is in the surgical smoke, but anyway, this is a prophylactic measure. Also, to remove the uterus or to remove any specimen from the abdominal cavity before we remove all the gas, with the suction device or with those filters located in one of the trocars, we remove all the pneumoperitoneum, and only after that we remove the specimens, the uterus or other specimens from inside the abdominal cavity. And we are happy with the laparoscopic approach because we have much more control on the surgical smoke than in open approach. We did a study in Portugal with the Portuguese Society of Minimal Invasive Surgery. The open approach, if you use an electrical bisturi, even with a suction system attached, the amount of smoke that is dispersed in the surgical room is much more in comparison with the approach by laparoscopy.
Okay, Professor, there's another question here. You mentioned about vaginal dehiscence with total lap hysterectomy. What could be the possible causes for this?
Most of the times, the vaginal dehiscence happens because of not good closure, but there are many other factors involved or risk factors involved that are published, like bad disinfection. There are some infectious agents in the vagina that can, the inflammation can interfere with the vaginal cuff healing, and then can be related with the risk of dehiscence. Also, the comorbidities of the patient, like all the vasculopathies, like diabetes, like heavy smokers, and other vasculopathies, hypertension. But as I said at the beginning, most of the times it happens because we don't close the vagina in a proper way. Generally, I recommend that we should close the vagina in 2 layers, one layer closing the mucosa and the other layer joining the fascia and the uterosacral ligaments. The type of suture can be important. You should use a good suture, but nowadays in the market we have very good options. And also, one of the most common reasons for vaginal cuff dehiscence is the premature intercourse. We should inform very clearly to our patients that they just can restart the sexual intercourse after we check. Normally can be between 5, 6, 8 weeks. We should, in the appointment, in the consultation, make a good vaginal examination to be sure that the vaginal cuff is closed, and only after that they can start the normal sexual activity. Because we have seen two cases with the loops outside the vagina, and it's a really scary scenario. And if we don't go quickly, it can be a serious complication for the patients.
Yeah, sometimes we forget that our patients will be engaging in sexual activity after the surgery. So thank you very much for that. We have probably time for 2 or 3 more questions. There's a question here from Thea. What is your opinion on applying an extracorporeal knot on the uterine arteries before coagulation? So probably Dr. Thea is doing a knot. She's securing her vessels. So what's your opinion?
No, it's a good question, and honestly, in the beginning and in some situations that, for example, we did not have a good bipolar for the uterine arteries, we used the extracorporeal. And the extracorporeal is a good approach because we control the tension that we apply on the tissues, that we apply on the vascular pedicle, and it works quite well. I have the nice videos with extracorporeal. The important thing of extracorporeal is that when you are pulling the thread, you should avoid that the thread moves or stretches too much around the pedicle, because you can lacerate the pedicle when you are pulling the thread. But I have a nice video of it, how we should do, but it's a good approach. For uterine vascular pedicle, if we don't have bipolar, or we can do both, but nowadays with these bipolars that I've showed to you, and if we use it in the good way, it works very, very well. But if you don't have a good bipolar, or if you don't have a bipolar, the extracorporeal suture is a good approach. I use it many times, and I'm happy.
Dr. TC, would you like to add something to that? Can't hear you, sir. Microphone, please.
Yes,
Thank you.
it's nothing to add. Was answered excellently.
Thank you, partner.
Sir, do you normally do bowel preparations before you do your lapis hysterectomy?
Not anymore. Not anymore. Now just the low residual diet, 3 days before the surgery, because it helps in the bowel mobilization. It helps in the exposure. If we do the bowel preparation, sometimes the loops can become very distended, and you lose exposition. But in the beginning, yes, not anymore. Even for endometriosis, we don't do. For endometriosis, sometimes if we know that we are going to perform a resection, a segmental resection, we do a low rectal preparation with a rectal enema or something like that.
Thank you very much.
What's the standard approach in your country? Do you still perform any open laparotomy?
Yeah, unfortunately, yes. Is changing. More and more centers are doing laparoscopic hysterectomy, but still many centers doing open. But it's changing rapidly. Last 5 years.
You mean
also,
you're doing more laparoscopy?
Yeah. And the patients look
you're
for
increasing
it more
your
and more.
laparoscopic.
Yeah. The patients they look for it more and more because the recover, and because all the benefits, you can do it in outpatient basis sometimes if you follow the protocol. And if you follow also the ERAS program, it's very important, the enhanced recovery after surgery program. It's very important to short the recovery, the after surgery, and is becoming more and more popular.
Yes, and
but we still have a long way in front. Yes, we need to invest more in training, in equipment, in adequate instruments, and also what you said is very important. If we don't have the adequate equipment, adequate devices and instruments, I recommend everyone to do not start or do not try, because if you have a complication because you don't have the proper instrumentation, no one will defend you, even the administration of your hospitals.
Yes, patient safety first. Maybe we have last question, one more question. Do you amputate the cervix above the uterosacral or across the uterosacral?
That is a very good question. Speaking about benign indications, nowadays after some experience, we cut above the uterosacral origins, because if we leave the uterosacral insertions, in terms of dations risk, in terms of vaginal cuff prolapse risk, can be better to leave all the pericervical ring with the uterosacral insertions in place. And it's possible if you open the vagina just above the uterosacral insertions. But at the beginning, when we started, it was very helpful to cut the uterosacral ligaments, because it's the same principle of cutting the posterior leaflet of broad ligament. If you cut both uterosacral ligaments, you gain more mobility of your uterus. You can push it more cephalate and more cranially, and then you theoretically can increase a little bit the safety and the distance between the uterine arteries and the ureter. But this is a feeling, is an experience. I'm not sure there are publications speaking about this tip and this small thing, but this is what I want to share with you. But nowadays, we always open above the uterosacral insertion for benign indications. But we have more experience, we feel much more comfortable with all the anatomy. But mainly for the starters, can be helpful to have more mobility and to mobilize more cranially the uterus. But anyway, this is just a feeling and just a comment.
Thank you very much, Professor. Thank you. So I know that there's still so many questions, but we're running out of time. We have to end this session. By the way, there are two things that you mentioned that I like. The gynecologist is the greatest predator of the ureter. Yes, and what you mentioned about the fat. The fat belongs to the bladder and the fat belongs to the rectum, not to the doctor. Right, thank you very much. Thank you. So we now call on, yes, partner.
Thank you very much, Professor. There are so many comments in the chat box that they enjoyed your lecture. It was very informative. Thank you very much.
Thank you. It was a huge pleasure. I'm very...
Next slide, please.
I think Professor has something to say.
No, I just want to thank again the kind invitation of the Philippine Society of Gynecological Endoscopy. I know there are many cultural similarities between Portugal, Iberia, and the Philippines, and some historical common origins. Anyway, it was a huge pleasure and honor to be with you using these new technologies, and probably one day I will welcome you in Portugal. We have a beautiful country too, or we will meet in Philippines.
Maybe we
Thank you very much.
come over and visit Manila.
Thank you. One day.
One day, yes, one day. Okay, thank you very much, Professor. So to close this wonderful event, I would like to call our energetic and always very, very systematic, no, very industrious, napakasipag, our Vice President, Dr. Habana. Ma'am Tonette?
Yes, thank you. Thank you for that kind introduction. It has again been an incredible afternoon. I would like to thank our faculty, Professor Helder Bruno Ferreira and Dr. Herman Tan Cardoso, our chairs, Dr. Ana Belen Alenzuela and Dr. Marinela Agnes Abat, and of course, our dear President, Dr. Prudence Aquino Aquino. I would like to thank all our participants for attending this webinar. I'm sure that I share the sentiments of our participants that we hope we can invite you again, Professor, in the near future, if not face-to-face, at least by a webinar.
For our participants, you will receive a survey after this session, and your feedback helps us choose topics that are relevant to your practice, and your input is greatly appreciated. A post-test will likewise be given. Professor Ferreira provided for some post-test questions, and this will be used for CPD requirements. The session has been recorded and will be available in the website of PSGE in the near future. This webinar is the second of a three-part series of webinars supported by an unrestricted educational grant from Karl Storz Endoscopy Philippines, for which we are grateful. Our next webinar will be on September 9 at 3 p.m. That's next week. We will discuss management of ovarian endometrioma with Dr. Delphine Tan and Dr. Clarice Haik. This is supported by an educational grant from JCS Pharmaceuticals and again Unilab and Biopharm for the platform. Dr. Gladys Tanangonan and Dr. Asuncion Fernandez will share the session. The last of the three-part series with Karl Storz will be on September 23, 8 to 10 p.m. Our faculty, Dr. Joan Tan Garcia and Professor Rudy Campo, will discuss hysteroscopic myomectomy and outpatient hysteroscopy. Chairs for this session will be Dr. Ann Trinidad and Dr. Gladys Tanangonan. So these are things we hope you will be able to join us also. We'll give you more information later on about our pre-congress, which will be held on October 21 at 4 to 6 p.m. Now, before we end, I would like to call back my dear friend and our president, Dr. Prudence Aquino, for a few words. Prudence? Perhaps.
Hello.
Yes, we can hear you.
Yeah. Hi, thank you, friend. The first time I'm going to open and close. The PSGE became affiliated with a very nice organization called the Healthcare Professionals Alliance Against COVID-19, HPAAC. And we were given this poster to commemorate Christmas at the same time to remind us of what we should be doing. So let me read this to you. Ano man ang uno sa ating buhay, ang sinag ng tala ay nagdadala ng pag-asa. So with that, we will always have to be looking forward to the bright future ahead as we deal with the COVID-19 pandemic that is still ongoing in our country and in the world. So next slide, please. So as a reminder, I said earlier that the PSG will have a special meeting instead of an annual convention and an election on October 21, 2020. This meeting and election shall be held at 3 to 4 p.m. That's prior to the PSGE POGS pre-congress on October 21. So the link for this online election shall be sent to you as you register to the event. So that ends the, so with that, I'd like to formally close this exciting session. Stay safe, everybody. And thank you very much again to Professor Helder, to Karl Storz, to my dear friend, Dr. Habana, for organizing this, and to the beauteous moderators, and of course, to the Dr. Tan Cardoso, the thorn among the roses of the BOT. Thank you, good evening, and stay safe. Bye. Okay. But first, bye. Yeah, there's we need to have a photo.
Yeah. There you go. Okay.
Do I do it?
Yeah.
Professor, as you would notice, we are wearing our national costume for you.
Yeah,
Yes.
I see. Very nice, very beautiful.
Okay.
And we love taking pictures.
Yeah, very nice indeed.
Again, thank you, Professor.
Okay, thank you.
Participating. Yeah. Bye-bye.
Thank you very much,
Professor.
everybody.
Thank you, Professor.
Bye-bye.
Stay safe and healthy.
Bye. Thank you.
Bye-bye. Bye-bye.
Thank you. Thank you, everyone. Thank you.
Thank you.
Lawrence, thank you.
Thank you,
Thank
Lauren.
you so much po.
Everyone.
Claire, thank you.
Jalen
Henry.
and
Stay safe. Thanks, Amy.
Henry, thank you.
Bye.
Thank you. Thank you.
See you all
April,
soon
thank
po.
you.
Thank you,
Yes.
Doc. Congratulations.
Congratulations
See you
again. One more.
One more.
Thank
more.
you.
Bye.
Bye. Bye-bye.
Bilis mo na eh.
Ang galing eh.
Pinatong yung kanyang blouse. Ang galing. Thank you, partner.
Diba? Prepared.